Thank you very much for inviting me to Oxford to talk about PresbyEDOF, a strategy to correct presbyopia with laser vision correction. That's my history in laser vision correction with lasers. It started 12 years ago with the PresbyOnt system. At the same time, I started this kind of blended vision with the Oculentis COM4, a segmental EDOF low aid plus 1.5 diopter IOL, and we then called it the Düsseldorf formula, and it was acknowledged in the category innovations and awarded by the ESCRS in 2016. So as we do a lot or have a lot of patients that are really demanding, we only have the best lasers at premium eyes, and so it was time to buy the world's fastest excimer laser. As I was talking to friends and who had the laser, and they especially also in hyperopic people said it's a fantastic laser because it has really an excellent eye tracking system, and they showed me their very convincing results. So I bought it. The problem was I lost PresbyOnt and one PresbyMax. PresbyMax to me seemed with a target refraction in the near dominant eye, so-called non-dominant eye, of minus 0.9 diopters, not enough, and the decision tree was, at least to me, a little bit too complicated. So plus the results were worse than with PresbyOnt. That if you looked at the literature, I tried to find my own way. That means I was transferring my experience with PresbyOnt and the Düsseldorf formula to create PresbyEDOF. So what was our approach? Basically, the Schwind PresbyMax routinely offers an anisometropia of minus 0.9 and 1.25 diopters of spherical aberration as EDOF effect addition. In our experience, that was not enough for high spectacle independence, especially when reading near and close. So what I did, I changed and said, okay, let's do an individual target refraction according to the patient's needs, and also an individual additional spherical aberration according to the patient needs, because our patients are all individuals. They have different jobs, different hobbies. For example, a hunter needs perfect far, a perfect vision in mesopic conditions. A man of action, a surgeon, needs perfect intermediate and near. Usually he has more than enough light, but the question is, does he have any special hobbies? I once did surgery to a moderator. He, of course, needed near and intermediate, but had bright studio lights, so we have to think about photopic phenomena. And he was in wintertime went skiing every day. So when we use anything for the first time, we initiate a quality management patient survey. We took the official one of the National Eye Institute, and we achieved our results after 3 months, because you need the time for neuro adaptation. 4 patients were excluded because they will get touch-up surgery, so we have to respect that, and it doesn't make sense to include them here, but we learned from them again. Proof of concept. Here you can see the induction of spherical aberration. The red line is the pupil of 3 millimeters, the gray of 4.5, and the green one of 6 millimeters. And as we see, of course, the smaller the pupil, the smaller is the effect of induced spherical aberrations. The wider the pupil is, the bigger is the effect of induced spherical aberrations. When we read with a small pupil, so we have a better EDOF effect only by the pupil, which counteracts the less induced spherical aberrations as shown here. When looking far with a wide pupil, we have less EDOF effect. That's when we need spherical aberrations for blended vision, but theoretically we might get more halo and glare. In myopia, we can see we go a little bit into the positive spherical aberrations, in hyperopia in the negative, in myopia up to 4, in myopia up to -1. But what we learned is that up to 4, you don't have nearly no photopic phenomena. No photopic phenomena is not possible. And -1 is in hyperopic eyes. So hyperopic eyes are small eyes. That's why we thought this might still be acceptable. So, but thinking and analyzing in a scientific way is one thing. The other thing is asking your patients. And here we have the results. And what is very important, this was 3 months after surgery, without touch-up surgery. And the comparison was all patients pre-op with correction, glasses and contact lenses, and post-op without correction. So over 85% were reading a newspaper with the aid of glasses. I think we got better in this as we are using more near edition now. So I will, of course, make a new survey again. More than 90% don't need glasses pursuing their hobbies. Over 90% had no problems when they went shopping. Most patients were driving a car without glasses, not according to the laws. The mesopic vision has improved. This was really, really surprising. And what was also good for the patients, that they better recognized the people at parties or at restaurants. Now, other questions? Do you have difficulties going to the movies, the theater, sport events? 18% had, and those were those patients who are in a football stadium, and if you're sitting far back, then of course this is very difficult. There you might need glasses, both eyes for far. Driving at night improved significantly. That was surprising to me. I didn't expect it. And of course the fear of bothering people was reduced. Some people said even small print reading has improved clearly. And only one patient said reading the receipt is more difficult. So the other question was, do you have difficulties shaving, styling, applying makeup in front of the mirror? And our patient said they even look better. So even better driving under difficult conditions was a real surprise for us, because as we all know, in the neuroadaptation time it might be worse, but after 3 months our patients said it's better. And when we asked them, are you restricted to do something you want to do, they clearly answered that the quality of life has improved and the patients were less restricted. So this to me was very convincing, and using a method that is safer than wearing contact lenses, we are able to improve the quality of life of every patient. I think that is really a good and excellent result. And now we come to the proof and concept. In the conclusion, I did this kind of laser surgery to myself. Here you can see the data. I had a so-called eagle vision, no detached vitreous, so for me a clear lens exchange was an absolute no-go. There was 3 years ago, I was 52, and I said, no way, I'm going to do lens surgery. If I have a tool like this, So you always have to think about the situation, but if the situation is like this, I think I clearly would nowadays go for laser vision correction. This is a treatment protocol, as you can see here. That was my Pentacam pre-op on the left side, post-op on the right side. Clearly a successful pattern. So it was epithelial perimetry pre and post-op, and a series 4 weeks post-op and 6 weeks post-op after surgery. You can see a clear successful pattern. After 6 weeks, I was really happy. I didn't expect to read so good. And now 3 years after, excuse me, okay, 3 years after, I'm still not wearing glasses, and you can see this beautiful pattern in the cornea for near vision. Here you can see the same pattern in the Pentacam, and it always becomes obvious in the epithelial perimetry. So today, after 3 years, I'm still smiling, and I really do think that in patients like me with clear lenses, that is very important. It's better to do laser vision correction than implant IOLs, because we all know that the decentration of an IOL is just one reason why refractive lens exchange is not as safe as laser surgery. The only argument is what about in 10 or 15 or 20 years? All we know up to now is that around about 30% of those patients we do laser correction in presbyopia will later on have cataract surgery, but only 30%. So I also ask myself, why taking a higher risk now when I have a safe procedure? And if I get cataract with 70 or 80, so what? Then I profited 20 years from that kind of surgery. Thank you very much for your kind attention. I'm looking forward for many questions.